Donc, la dernière table ronde avant.
So the last panel discussion before we hear from the minister is called "The Time for Change is Now," with Jean-Marc Daniel, Antoine Debout, Sacha Loiseau, Emmanuel Quillet, Sébastien Mouinard, moderated by Didier Bazocchi.
Bonjour.
Hello. So change is now. It really is now. You have 4 hours. Each, yes? And then we'll be picking up your papers. No, that's a joke. Now, the Minister of Health announced a few days ago that there would be a consultation on the healthcare system with CAPAX. We're turning to prevention. We're turning to fighting against social and local inequalities. We're thinking about making the healthcare system more relevant, focusing on innovation, all kinds of innovation, technological, digital, medical. We'll see whether change, that's what it's really all about later on. Let's divide this up into 2 parts because you represent different professional sectors from the health field. We've got the economic sector, economic theory maybe. So I suggest that we divide this into 2 parts. So what is your perception of the current situation, first of all? And then let's spend some more time on what do we need to do now. So I'll be like Jean-François Lemoine. What do you suggest? So let's start with Antoine Debout. You represent private hospitals that are not-for-profit. What about the difficulties? What about the progress? How do you see things today? So the main difficulty, we've talked about it in the different panel discussions. There's this inconsistency that we are seeing between the analyses that have been carried out. We're pretty good at analysis in France, and then the conclusions and decisions made. The first is that we've talked a lot. We've talked about the life path, the healthcare path, of putting the patient at the center of everything as an objective. And at the same time, the answers concern the number of beds, the facilities, the governing bodies, the status of personnel. Where we've still got financing that is difficulty. It's difficult to understand how it operates, this financing. And then there's something that struck me in the debates. Perhaps this is what the FIAP does. We've talked about prevention. We've talked about first recourse. But I think yesterday we never talked about medical and social aspects. And these are important when it comes to managing patients. So that's my first remark. The second remark, and then I'll stop there, is the notion of responsibility. Instead of talking about organizations, talking about drugs, perhaps we need to think about whether the governance model that we have is the relevant model. Now, I believe that it's not relevant for at least 2 reasons. The first is that the state itself has a conflict of interest. The state finances, legislates, employs, manages, all at the same time. How can you expect it to work? That's the first thing. And I'll try and answer those questions later on. The second is that with the irresponsibility that we generate, in the responsibility that we generate, that you've got the role of the mayor. Elizabeth brought this up. I'm sorry. How can you preside something if you're financially irresponsible? It's something that just is not understandable. That's a great introduction. So some questions. We'll see how we answer those questions. Emmanuel Quilez, you're in charge of a big French lab. So you are in contact with what's happening elsewhere. When you look at France, with that point of view, what do you see? I see many things, because the question is to know whether we've seen any changes that are being operated. There are some that we haven't seen. Well, there are data solutions. This is terrifying. When we look at the figures with respect to the last 2 years across the world, we've produced more data than since the start of humanity.
That's astonishing, mind-boggling. And I think for healthcare data, it's the same thing. We're completely submerged in this huge quantity of data. So there are many issues. First of all, how are we going to share it? Who is it accessible to? Do we make it accessible to patients or not? Do we share it with drug companies? That's another issue. Do we share it within the same healthcare facility? So there are many questions around data. So for me, that's really the core of the debate. We've also evoked patients, their role, which is increasingly visible today, and that's an excellent thing. I think we should stop saying that we're doing things for the patients, and we need to say we're doing things with the patients. That's a huge change. Yes, people have been saying this for 20 years. Well, when you do things for patients, you don't do it with them. Well, you have to involve them. We've seen this at our expense. The Transparency Commission today, there are patients on the Transparency Commission, and they give their opinion on a certain number of drug issues, and yet the pharmaceutical industry is no longer a member of this commission, the Transparency Commission. And if we eliminate the pharmaceutical industry from the commission, do we eliminate the problem? No, 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 no. No, I'm just saying that certain choices were made. We understood that the patient had their opinion to express on things that were even fairly technical. Yes? So the focus is turning more toward the patient. Yes, absolutely. Sébastien, you're in charge at Air Liquide of eye health and chronic disease. I wonder, when you talk about e-health and chronic disease, that's a position, but what about doctors and the non-technological aspect? Is technology going to solve everything? What is this? Can you tell us more about your job? Well, obviously, technology won't solve everything tomorrow. We need to combine humans with digital in the future. That's obvious. Let's focus on the subject of telemedicine, for example. Telemedicine is remote asynchronous medicine. In 2009, it was officialized in French law, and the legislator has planned for experimenting in 2014. And today, telemedicine in France is just at the embryo stage. Well, it takes a long time. Let's come back to the benefits, first of all, of e-health. I think we can categorize them in two chapters. You have tele-expertise and tele-visits. This is what we heard about yesterday in Sweden. A doctor can have a consultation with the patient remotely. But tele-expertise allows one healthcare professional to share his expertise with another healthcare professional at a distance. Yes. So there are two topics here. It's quite different. And the PLFS has provided for this. So the idea is to departition the territories and to... Then there's a second issue that we can talk about, which is telesurveillance. Telesurveillance has an impact that's very significant on the patient. So let's take 3 minutes what I mean by telesurveillance. You connect patients with medical devices at home for diabetes or a scale for someone with cardiac issues. And all of this information is processed by algorithms, not artificial intelligence. Then our nurses reanalyze the algorithms, and then they transfer this to the doctor, who can take a decision. Now, there was a report that said this could save 2.1 billion euros for the healthcare system and avoid hospitalization. But from a medical standpoint, for patients, it's 20% additional survival for cardiac patients and other patients. So this digital transformation has a massive impact. That's what we need to do today. We need to go down to a very concrete operational level and say, what in the future will we be doing in the hospital, private practice? How will they be controlling their activities for the patients? So yes, there are some issues of governance and financing, and obviously question of access to data as well. Yes, but there's also the issue of moving away from a sort of a theory. People, if you're in favor or not of big data, that's not the question. The question is, how will we succeed in understanding the daily impact for human beings, doctors and nurses? Well, we shouldn't simplify. There are some societal issues here. The protection of privacy, private data is a huge issue. These are societal issues that we can't avoid. Yes. But I think, are you dealing with these questions? Well, in France, we're lucky enough to have a data protection system based on the CNIL and other mechanisms that guarantee one of the best privacy protection systems in the world. Can you all work with this system with no problem? Well, that's a good question. I think one of the obstacles for telesurveillance is indeed that some patients don't have access to the data. Well, the federations, hospital federations, had to fight to have access to the data because it was taken away from us. Well, we will come back to that. That is a real topic. Sacha Loiseau, you founded a medical device company, with innovative technology since 2000. I was really struck by the fact that you were the biggest new introduction on the stock market in Europe in 2011. What about EDM in France? Does that still exist? Yes. If you look at the innovative medical devices, there's actually a paradox. What happened in recent years is that we're actually becoming a startup nation, just like Israel, and medical technologies represent a significant portion of this development. But we're actually becoming a startup nation which is shooting itself in the foot, because on the other side, in terms of the development of the French market and access to the French market for these innovative medical technologies, there's been no progress. So, can you explain why? Well, we heard this in several roundtables even this morning. When you develop a real breakthrough innovation, and this is the key point, what is a breakthrough innovation, a disruptive innovation? Well, you can't pigeonhole it. It doesn't fall into an existing category. Well, in France, people haven't anticipated it, so it's an unexpected journey, if you will, and it's a difficult journey for those of you who've done these obstacle courses when you were in the army. There are 20 obstacles, and you can train for that, and you can become really excellent. But in France, it's sort of a black tunnel that you enter, but you have no idea what's inside. So, concretely, give me some examples. Where are the problems? Well, the adoption of a medical technology, for it to be massive, it has to be reimbursed in France. So, okay, now I get it. I see what you're getting at. Yes. It's not just a problem of money. There's also a problem of culture and what we call TAA that you were talking about. If you have a technology that is reducing the useless surgeries, for example, or useless treatment, you won't have an echo in the hospital or the clinic because you're going to actually reduce the income of the hospital and the clinic. And if you're not reimbursed, there's nothing that you can offer as a counterpart. So if you arrive in a new clinic with this disruptive technology that's not reimbursed, you say, well, you should buy my technology. You're going to use it in your clinic, but you won't make any money and you won't be reimbursed for its use. And in addition, you won't even have certain types of surgeries or procedures that have become useless. Well, then, from the standpoint of the director of the hospital or the clinic, that's certainly not attractive. Well, what about selling abroad? Well, that's what we all do. Most of the companies actually generate most of their sales for export. For us, it's 97% of our sales outside of France, and that's not a success. People say, oh, fantastic, our companies are exporting. Well, in medical technology, our trade deficit is highly negative, whereas Germany is exporting 28 billion and importing only 8 billion. So they're in much better shape than we are. So it's not a success to be exporting because it's a triple sentence, if you will, against you, because it's already difficult to find capital. But if we can't succeed in finding your market, your domestic market, then very fast you have to go and find international capital elsewhere, and that's difficult. Obviously, it's much easier just to take the subway or the TGV to go and have discussions with doctors in your country than to go to Germany, England, the US, China, or Japan. And when you arrive in these countries, obviously, we would love to be able to tell them we are a huge French reference in the French market because the French market is a significant market. And so when you're talking with a German doctor who says, oh, that's great, you're techno, but my friend, Professor so-and-so in Lyon, does he use it? And you say, no, he doesn't use it. Well, why not? Well, because he can't finance it. Well, that's not the only problem. I had discussions with an IT researcher who said, when you set up an operation with a major hospital in France, a university hospital, it takes 1 year to 18 months of discussion, and he works in Singapore, and it takes 48 hours. And that's not the case. Well, you're mentioning Singapore. We could also mention Israel and Ireland that are clusters of medical technology. So what's the difference with France? It's not a problem of money. Well, there's an administrative problem and a cultural problem. There's a true, profound cultural problem. We need to change the relationship between doctors and the startups, and industry, if you will. But these are mostly small companies, startups, and nobody's really understood how we can create this interaction between medical technology developers and doctors. Often they're young people who arrive like an elephant in a porcelain shop, and the doctors aren't used to this. And then there are all these administrative obstacles for the clinical trials. We know how hard it is to have clinical trials and how long it takes. So when I said we're shooting ourselves in the foot, what I meant is that we have doctors and surgeons who are extraordinary in France. We have researchers and engineers who are fantastic. We have ideas, many ideas, illustrated by the fact that we are the second country to register patents in Europe and the fourth in the world. But we can't succeed in creating these world champions. There are no large medical technology companies in France, not a single one. And there are 15 companies that generate more than 50 million euros in sales. So people say, that's great. There are companies that have existed for 70 years, but there are 50 companies in the US that are generating billions in sales. Well, that's not true in the medical sector. But it's extremely clear in our sector. Well, now, what do you propose to get out of this situation? We'll go back to that later. But Jean-Marc Daniel, you're an economist. You're very well known. You hear these professionals talking about their challenges. How would you react? Well, being the last, I can react to what everybody said. And I found it interesting when you said that our leaders talk about inequality and innovation, and you forgot the word competitiveness. Politicians are always talking about innovation and competitiveness. Well, that's the health minister that talks to that. No, I think all of the politicians are talking about the fact that we're not exporting enough. So we hear all this hollow rhetoric. We've heard this since the 1950s. But the real challenge for me is, are we for or with the patients? And will the state continue to meddle with things that are not its business because there's a situation of conflict of interest? Will the change get rid of this mindset where we're working for the patient and not with the patients? So working for the patient is say, okay, I know and you don't know as the patient, and I'm going to give you something, and you should be kind enough to say thank you to me as a doctor. Now, my question is, these new technologies, the world that is changing, because change is now, does it allow us to work with patients? I think we are moving away from a society that was the society we knew in the 1960s. People have this nostalgia for those 30 prosperous years. And now those of us who experienced that period are being accused of having lived in paradise at the time. Well, that's not false. Well, no. I don't know if our children will have such prosperous lives as we did, but let's remember that this was just after the war. Some people had actually ration tickets, so it wasn't that great. And we are the country. Well, if you look at the highest growth rate in the world today, it's Ethiopia. So I don't think that many people really want to go and live in Ethiopia. So we're not so bad off in France. Now, France had all of these state monopolies. It was a capitalist, monopolistic country, and then prices were very high. Regulation came in. The system was more or less balanced, but when it generated deficit, people were convinced that inflation would erase the debt. So there was a form of regulation in which we were subjected to the system. Now I think we are in the popular, competitive capitalist system where the patient is taking more power. So now there's more competition. That's what a platform does with the internet. It places people in competition. And so it's a competitive society, and that has an impact on healthcare. So the monopolies that continue, and our healthcare system, the social security system in France, is a monopoly that can be defended from the ideological standpoint. So this goes back to 1945, and they say, I'm untouchable. I'm a system that you created in 1945 in France. Well, healthcare is not a good like any other good, and that's been defended by economists. So this is not a market. It's not the automotive market or a toaster market. No, I agree. Health is not a good like others. But you have the doctors, you have the patients, and the doctors usually think they know better than the patients. There's an asymmetrical information exchange. Well, why? And then you have a third party. You have that in healthcare with the financial organization. And this financing organization is a monopoly in France and I think that modern society wants the end of this monopoly. And in my opinion, it failed in three ways. First of all, change. We were expecting change and it didn't happen. The CADES, we hoped that it would disappear, but it didn't. There are 140 billion that need to be reimbursed. That was created in 1997 for 15 years, the CADES, and it's still there. It's still there. Okay. The second element that I think was a failure is that just like any monopoly, there's the black market. People find it absolutely unbearable, and they try to get around this. Well, there are two types of black markets. One is fraud. People try to get around the system. So that's about 100 million per year. Well, there was a report produced where they said it was 210 million euros. But that's not that important in terms of order of magnitude. But you also have the public authorities saying, okay, I'm getting rid of the minimum revenue, the minimum income, the RSI. But the recognition by the authorities that the system has something wrong with it. Every time we talk about competitiveness, people say we have to reduce social charges. What is that? Well, that's what actually is the income for the social security system. It's something that's taken supposedly to finance the social security system. So this message that says these charges are too high, you see that in the political world and also in people's daily lives, this is experienced as illegitimate. So I think the system is condemned, if you will. Well, let's go back to this. Well, there is that question of equity or equality. Not all of our healthcare expenses can be covered. They can't be insured. We can't. It's not just a usual market phenomenon, and this is described by many economists. We have a problem of access to healthcare, equality of treatment, and healthcare, which is health, which is. We have a problem of management costs that we can discuss here. Let's not enter that debate, but it's not so obvious.
And it's even debatable. The central subject is the access to care and fairness, equity and fairness, that all of our citizens can get treatment when they need it, regardless of the amount that can be very high for this expenditure. And someone even not be able to get insurance. No, it's a political debate as well. Thank you. Yes, we're talking about fairness, but if you have a sector where they tell you that if you want to an ophthalmologist or the oculist, or you have to go through the usual network, that's simple. The insurers know how to do that sort of thing today. Yes, but what I'm saying is, but the current system is not fair. It claims to be fair, but it generates a black market. That's to say that there are people there's a queues and people jump the queues. There are extra charges for certain. It's not just for those treatments. There's all kinds of treatments where that happens in France. I can hear that, but in daily life, but we'll talk about that later. So we're going to move to the second part. You raised some points with the end of certain. Most of the people in this room are quite interested in this financing. There's another subject that we'll talk about later. I think that we should move on. After this diagnostic roundtable, we should move to something which is more delicate, a more delicate exercise. That you should each propose your solutions. You're not going to be an minister. You're going to be the power behind the throne. What would you do? What would be your suggestion? Who would like to start? I'll start. Recommendations. There are already some that have been implemented. So finally, I feel perfectly aligned. The minister was courageous to decide on a certain number of these projects that relate to the long term, which I think was excellent to do, because if it's not done, things aren't done right from the beginning, they'll never get done. And that's the subject of the coverage for vaccines. I think everyone was expecting this, and we don't just sell vaccines. We know their importance. It's also good for the pharmaceutical industry. I don't produce any vaccines, but that's not what's going to transform the difficulties of the systems. How can we, if nobody works for the future, nothing ever going to happen. So I'm sort of thinking there are things that have to be done in the long term that no one will assume. The second I would recommend is there be digitization. There's a real topic there that I was saying earlier. I'm scandalized that with our hospital we can't even share data. I'm not talking about the view from the exterior where it's ridiculous. I have trouble explaining to people what's going on in France. That within a given hospital, there are the hospitals that have looked at this subject, trying to say that all the data within a single hospital are available. To go from the child sector to the adult sector, your file is not your file won't be transferred, and that's Kafkaesque. But that's an organizational problem. But it's a problem of governance. The organization has to be reformed. But when we say that, there's a real subject as to how. Maybe I'll talk about it later. I'm going to come back to the subject that I know well, and that's the assessments or appraisals. It was also mentioned yesterday. There's too many committees today. There's too many people deciding. So what's great with the government, which is really overturns, shucking up on a lot of people in this room. We have a government that's trying to get things done. Instead of saying it's complicated, we can't do things done, we can get things done quickly. So there was vaccination and tobacco. It's good, but it's not that's going to deal with a certain number of index subjects. I can come back to innovation because earlier you talked about access to data. I think that's we have data sharing which is available. There's a system that's been set up for laboratories where we can access a certain amount of data, which are health data. And I would remind you that everyone personal data is not of any interest to laboratories or insurance either. And we're interested to know how these medications are used. and other things, but the strategies, therapeutic strategies, and to see exactly how our medicines are used. Each one we had to do set up appraisals that's going to cost millions on each side because we're asked for extremely complicated schematics. We have to simplify things and we have to make the system more fluid. We have to have one structure that controls another structure that controls another, and 3 years later that will allow us to have access to data 3 years later. It's ridiculous. So congratulations on the vaccine and tobacco. So now data access. Yes, that's one of big data and access to innovations. Access to innovations. So we have breakthrough technologies or breakthrough developments. That's to say that we don't have the right. We have the right criteria to assess them. We're still trying to put them together. Our criteria, the current ones, are old, and we have to have new criteria for assessments, and it's ridiculous. We have products that had. Take more than 500 days to get onto the market. It's ridiculous. It's not the reality. Right now, the European regulation says that we must be able to, once we have the marketing authorization, it must be available within 180 days. The average in France is 400. It doesn't shock anyone. In the laboratories, are we going to attack the authorities anytime we get past 180 days? I ask you that. No, it's ridiculous. Some that can take 700 days. It's ridiculous. So we have a second proposal here. So access to therapeutic innovation on a more rapid scale. Sasha, perhaps. So what do you propose? 700 days? That's a dream. That's great. Only 700 days. You think about changing jobs? 700 days, I wouldn't even calculate. 4 years to get one favorable opinion, 3 years to get another favorable opinion for the rates. We're not talking about 700 days, we're talking 7 years here. So anyway, just to finish up on looking over what's positive. We have a lot of companies that are being created. We always know that we're very happy in France that since about 2000, we've set up all kinds of things for people to create companies. That's great. And we can get them to a certain stage where they maybe have a first product. So in the innovation domain, what we need is to have the French market. Hang on. Now you're a minister's counselor. What would you propose to a minister? The famous ATU. No, of course you're defending your industry, but when you're a minister's council, you have to have a regional interest which just goes beyond just your company. I won't. What would you propose? So we need the ATU for the EDM. So we need a temporary reimbursement with a whole system for risk sharing that will allow us, once the system has been validated. It's not a little thing in the laboratory that rolls on a little table. We're talking that's something that's already had a HCA mark that's been supported by other markets. There are publications that have shown it's a benefit for the patient. And for the whole health system in general. So once again, it's perfectly safe. It provides a benefit. We also need to be able to get temporary reimbursement quickly with a whole system that will allow us to measure the success metrics from the usage of this EDM. So we can come to another subject, which is virtual reality. Because unlike reality, everyone knows that it's operator dependent. You have to be able to train people, users. You have to be able to monitor all these metrics. So today, we talked about we can do them abroad, but we can't do it in France. We can do it in certain areas, particularly in Germany. We can get a temporary reimbursement. But it's changing in France in certain areas. Recently, there was a publication on its openness to virtual reality appraisal, whereas the dogma of the RCT to come back to reimbursement, we must be able to, once we've gotten beyond a certain stage of development, we have to go see a hospital. So here I have a technology. It's already proven that it is beneficial for your patient. Your physicians need it and they want it. I can sell it to you. You can use it. There's a reimbursement. And together we're going to measure what it provides in the health pathway, if we can avoid certain useless procedures or whatever. But today we've heard And yesterday, were talking about the innovation package. In fact, it's pointless. There's currently no demand for the innovation package. Why would you replace this innovation package? When it was redesigned after its first version, which totally failed, which had 2 candidates and 5 hits, it was just the financing of a technical study. And it didn't finance the equipment. It only financed part of the technical study. It allowed you to only finance part of the study. That's what we asked for, this temporary reimbursement with measurement of the follow-up and the usage of the system. I think they've been listening to us, yes. The minister understood that the innovation package, as it's been redesigned, only had one demand, one request, which was very complicated, and there are no other requests in our association where we have 50 members. There is no request other than the one that was for this innovation package. There's no demand here. Because we know how to finance our clinical studies. We're happy to have financing, but that's not the point. So that's the point that's essential for us. So you're saying the innovation package is essential to have a new innovation package with reimbursement, temporary, as is the case for medications. So we want to be able to use recent and modern technology that's efficient in order to provide this to the patient, in order to build a system. The necessary conditions for a new system. They're not sufficient. We also have to implement this virtual reality appraisal with all the innovations and technologies that we've seen all over the place. We know that the standard evaluation no longer works. There's a whole lot of work to be done on working on that. And if we want to take this somewhat further, we want to have long-term measures. There's a cultural change that must be made, because I think that in their training, physicians must come to industry, and particularly in startups, in order to understand what's going on. And here again, we're coming back to the fact that in France, we still haven't managed to recreate what that would exist in the United States or Singapore, Israel. That's to say clusters. That's to say places where we have hospitals, which are very high-performing, universities, laboratories, startups, and around that, they're in the same area, right in the same building. It's not a question of having to take the subway to a decision. So I go out of my operating room, and I can be walking and talking with somebody from a startup in the same building, and they might tell me, no, something isn't working, have you changed anything? What? That's one example, yes, but there are lots of, this example can be reproduced in other places as well. So 3 foundations. So fourth then, the last one is the financing of these companies. But that's the market. That's more or less the market, yes. We need these companies to have the possibility to develop. So you mentioned our IPO. It's around 120 million euros. That's great. In France, that's very significant. It's ridiculous compared with other places. In the United States, we have companies that they're pre-revenue, they can raise $500 million, and they still haven't done anything yet. But we know that in order to create a breakthrough in surgical robotics, people know that we're going to need that type of money. So you're going to gas some other people. You're going to bother some other people with your claims. We have to create some investment funds that specialize in medical technologies. But that's the market. Once you have your viable project, it's the market. So what's the point? So you're talking about the government here? Yes, but with a specialized fund for medical technologies. So 4 recommendations: financing, early financing assessment, clusters, and participation from the public in investment. So the minister will have heard you. Sébastien, how about you? You talked about telemedicine. And teleconsultation has the characteristic that it doesn't have a price right now. A patient doesn't want to pay for it. Since yesterday, we have some good news. So explain to us. Tell us about this pricing, and tell us what you think has to be done now. So what we understand from the PLFSS that came out a few days ago, teleconsultation is going to be priced so there's going to be prices that were good. And this is going to be brought into common law through the discussions with physicians. It's important to align to give physicians the ability to be paid and remunerated. So on the levers, if I was talking to the minister, I would say that there were three things. But I would be also very modest because the transformation, digital transformation, is not just technology. It's a collection of men and women who have to change. They have to change how people work, and we have to do this methodologically. We have to be aware this is going to have an impact on the lives of the people. So the three bases. There's data security. That's the key one. We've talked about a lot, but it's important. It's the first base one. Second one is the DMB. We talked about that earlier. We're not going to come back to it now. It's coming. I think the approach of the ACNAM is interesting. That's not my levers, but I think the ACNAM is already handling with that with their idea of decentralization of the DMP. And the third basis, is assessment. We have to assess health technologies that has an impact on our behavior in a very different way. A medication, where there's a direct causality with cause and effect, that's great. But in e-health, there's a lot of waiting for that. So those are my three proposals. Well, again, with a lot of modesty. I think we have to go down to a pragmatic level. We have to have these debates, which are useful, of course. They're also in the state, and we also have to go down to a pragmatic level. We have to understand that today a physician in the future might have a remote consultation. He's going to have data coming in from his patients, from 10, 20, 30% of his patients. He's going to have to handle. He's going to have advisors, the opinions of his physicians, and that's going to transform the transmission. So the first question is, how are we going to do this? How are we going to do all this? How are we going to handle all this? So finally, we can work with hospitals and doctors. We can find an initial dimension. Yes, it works. We don't have a lot of background right now, but that's the first question that's asked of us by hospitals, by physicians and hospitals, private doctors, and they're understanding the change of this value chain. It's fundamental to understand this on a very micro level, because if we don't agree on this vision, it won't work. That's going to please Jean, because in the field, things move in the field, and otherwise you're going to feel the impact of it. The second thing, it was mentioned yesterday, is aligning the encouragements, the incentives. So we have good news on the teleconsultation. We have to recognize the cost for one person, revenues for another. So if we're going to reduce by 20% of the hospitals are going to say, but our revenues are going to go down. We have to have a system when all of the actors have an interest in having these technologies that help to save lives of people, and have encouragement incentives to do this. So it's not technology that's the only thing. Of course, we have to have better technology, yes, but it's incentives that make us use e-health. This is just a moment. It's not that easy, because we saw that in the previous debate. Antoine talked about it earlier. As soon as we move the financing system, as soon as we want to organize a pathway, we have to ask who we're going to entrust the budget to, and there are considerable stakes. If this is the heart of the subject, is probably the most difficult subject to handle. It echoes Antoine's introduction earlier. You stole my third point. You stole my thunder. So the third lever, I'll be very short. Obviously, the transformation is digital transformation. It can't be an annual thing. So the PLFSS, that was created by the Juppé government in '96. It's '96 is a great tool, but it's quite a bit. But the efforts in 1 year, you don't have a lot of maneuvering room with the PLFSS. At the end of the year, it must have a series of cones. If you want to have the transformation in companies like ours, you have to have a view over several years. You have, for certain structural measures, you have to be able to have a structural imbalance with a promise negotiated with you. So you have to. My boss looks at me, my annual objective. So I think that for certain structural measures, we have to a trajectory that spans over several years. It's just simply because the very nature of digital doesn't make you change from one day to the next. You can't change your hospital resources from one day to the next. And we can't invest from one day to the next. We can't invest millions. But structural and financing, that's good. Antoine?
So what about governments and conflicts of interest? So I'll take over, yes. I think the measures that we need to take involve letting in some air. If regulations are necessary, regulations are not there to protect the system. We have to be convinced of that. Our system is a good system. We've got a good rating internationally when it comes to management, but it's good because the professionals are good. And I'm convinced of that, not because the organization is good. It's because the professionals, the doctors, the hospital managers are competent people. They've been well trained. But they mustn't be disgusted by their job. No, I'll come back to that. Yes, they need to have a breath of fresh air. Now, measures. I think it's fairly simple. We need to create a wall of China between the legislator, the financier, and the state that operates and employs. This is something that exists. It's possible. It doesn't require a revolution. The state has already done that with the Cancer League. We have an association-based structure that works. So you're pleading for the idea that all public hospitals have this model. So let me just explain what I mean. We've got to create the wall of China. It's something that's possible, even if we keep the status. So create the wall of China, build it, and regional health authorities should no longer be the bosses of hospitals. So there's a regulatory role that the state has to play here, yes. But it's not the regional health authority that will appoint the general manager of a hospital. It's not the minister who appoints all of the doctors working in a hospital. So that all looks great on paper, but I can't understand how that might work. For it to work, as you say, you need a civil society that is organized so that it can appoint the general manager. That's not what I'm saying. That's not what I'm saying. There's an old tradition with other structures. I don't see how the switch works. Let hospitals choose. A few years ago, I wasn't in the sector at the time, I think that the Strasbourg University Hospital was 2 steps away from adopting this status. So that's your proposal. Yes, just a minute. So I think that's the first thing that we need to do. The second thing is that we need to work on accountability. Public healthcare facilities need to be responsible, accountable. It's very difficult to prevent mayors from presiding hospitals, even if it's optional. I think in 100% of cases, the same thing happens. I think we have to be very simple. Either the mayor wants to preside, and he can do this, and there he's financially accountable, or he doesn't want to preside, or he doesn't want to be financially accountable, and so he doesn't preside. It's very simple. Intellectually, I don't know what we can use to oppose that. And if nobody wants to preside the hospital, it is a public service, after all. And there is a principle involved, local access to the public service. Somebody needs to be responsible for that. Somebody needs to be accountable for this human organization. We've been talking about these ESPICs. I am chair of one. There has always been a president. Give me an example that doesn't have a president. There are 900 beds, practically, and there have always been presidents of this kind of facility. The only difference is that I am responsible. I am accountable, and in spite of everything, it's a bit of a thorn in my side. And we haven't finished. Now, the third idea, which seems to be very important, it concerns bringing down management silos so that for the healthcare pathway, the life pathway to be smoother. The way things are organized at state level, so we've got this trickle of financing, and then through to the last step, the whole thing needs to be revised. Let's merge the GGCS and the GGOS. Why can't we do that? At least we would have a global vision of management from the medical and social right through to the end. I thought you said that the budgets had to be merged rather than the governance structures. Well, yes, budgets, yes, but that's a different matter. The first thing, the prerequisite, is to have an organization that makes it possible to manage the whole thing. And then I have a third, if not fourth, idea, something that's more provocative, I'll say. We've spent 2 years, 3 years, 4 years trying to reorganize our administration. Local authorities in France. We've created big regions, XXL regions. Why do we not entrust to them the healthcare policy? Why don't we regionalize policy? Not in terms of resources, because resources have expenditures, that would be complicated. Let me just remind you that that was the idea, regionalize the healthcare policy. We're trying to give power, we're trying to set up big local authorities, but we're not going through to the end of the process. That's not what the Germans did. We could talk about autonomous budget. If you give authority without a budget, yes, no, you entrust them with the budget, but not the resources. No, not the resources. There's a difference. That means so you don't need the same thing. So you need assessment sheets. No, we've said, first of all, that we have to trust people. Why shouldn't the regional presidents, the regional authorities, not trust in these organizations? Thank you. It's a novel idea, some novel ideas. Now, Jean-Marc Daniel, can you go into these visions? What I find interesting in what's been said, systematically, the idea that we have to bring in a new breath of fresh air into the system. We've talked about the hierarchy, we've talked about the PLFS, but it's just based on accounting. It's not a tool. However, what is this vision of health where it's the parliament that votes on the population's right to be ill? So it's the parliament that decides whether you're going to be ill or not. Well, if it's a public budget, somebody has to decide. It's better now than it was in the past. So for those of you who are in the room, you know this. Before the parliament votes, I believe it was worse in the past. So have we adopted the right strategy? Yes, the parliament votes on public resources, but it's not a public resource. Social security has a status, somebody who is involved in public service but with a private status. And once again, it's a monopoly. Now, current society, should it be still organized around monopolies or not? So the PLFS is the ultimate form, the ultimate end to a process that no longer corresponds to the state of reality of society. So concretely, I'm sorry to interrupt you, but I think that you're mixing up the question of the attribution of resources based on solidarity, national resources that guarantee the access to healthcare to each citizen. Today, that's the vision that we have of a French society, and probably European society generally speaking. There's no private major system in Europe. What do you mean there's no major private system? Apart from Switzerland. I should have said in the European Union. Let's talk about Israel. When you're an Israeli citizen, you ask you're asked what the social security fund is that you want to contribute to. And they say, well, if you contribute this, I will guarantee that. So you're differentiating resources and management. No, what I'm differentiating, what is important in this kind of system is that you have solidarity, and society must manage solidarity. And then you have the differentials. Now, this current system, because it mixes up both in a structure that has no accounts, no reporting to do in terms of management plan. When it has a deficit, it passes that down to the next generation. All well and good having solidarity. On those terms, my children are going to pay. Let me just interrupt you again. Sorry. A message of truth can only be assumed by citizens. And the citizens, either they recover that money and they say, OK, that's democracy, we'll vote on a PLFS and we'll maintain it. But, we've never dictated to people whether they were allowed to be ill or not. So since it was voted in, it's only been 2 years. So it's a situation that is paradoxical. We set up a system that is based on illusions with double sanctions. The first is that you have this system that generates deficit, and it passes down the consequences of problems onto the next generations, and the population has no choice. The population cannot say, just a moment, I'm not happy with the way things are going. I want to go and see what's happening elsewhere. They can't do that. And this is important. It's important to look at this because new technologies are encouraging populations to step aside from the system. Now, if I think about two people from the field, Emmanuel, Antoine, do you prefer to work with health insurance funds or with the social security system? No, sorry, can I just finish? Do we want to keep the social security system? Of course. You've got an organization with a deficit. It's not a question of access to health care. It's not free. If it was... So we're talking about a breath of fresh air, letting that into the system, but access to health care has to be based on a universal system. If you ask the French whether they're paying too much, they'll all say yes, they're paying too much. Any electoral campaign focuses on that. Those who say that they're going to be bringing up the charges, well, they're not going to be elected. Do you know any party that bases its election campaign on that kind of subject? It's costly. It's costly for the generation that follows. Now, let me just take 3 concrete measures. And then a piece of advice to ministers and doctors. We need to interfere as little as possible. The first thing is to look at organization, to organize how to bring in this new lease of life, focusing on the social security, which is the historical operator, like France Telecom was the historical operator of the telephone market. Now there is some competition. We can introduce some competition to the social security system. Now, to come back to financing modes, I think that in the financing of health, this is a general problem for the French economy. And here again, now it's not social security as an institution that is at stake, but the way we think about pensions is wrong. We need to think about pension funds. The French need to own their own economy. It's popular capitalism that we need. And the last position, I don't see why not. There is a public hospital function. I think that the status of somebody who works in a hospital should not be a civil servant. It's not about a career. It's about, providing health care. So we need to give those people a private status. Thank you, Jean-Marc. We have 5 minutes left. Emmanuel and Antoine, would you like to react to that? And then you can give us your conclusion. Well, personally, I'm not here to take the social security system to court. I think it has to be a system that functions. We can challenge it in the long term, but at the moment it's there, we have to make do with it. For me, well, I've never seen so many brilliant minds over 2 days. There are so many people who have been to great schools in France. There are some brilliant ideas being debated, but we're still able to act, and that's the most shocking thing. We're trying to there's the hospital with the question of home care. There are many oppositions that we've heard, and I think that's ridiculous. Today, we're in charge of healthcare. We're not playing a finite game. It's an infinite game that nobody loses, nobody wins. Today, we should be here to talk about patients, and they are the ultimate goal. What we're seeing is territorial wars. That's ridiculous. I'm very sad when I go to hospitals and I talk about general projects and the management refuses to talk to doctors. So there are people in the same room who don't talk to each other. It's shocking. We can all have organizational problems, but each person defends their own territory. I think it was Guy who was saying this yesterday. He said that we need to get rid of the courtyard around the President of the Republic. He also said we need fewer doctors because with automation, there will be a number of transformations taking place. I think there's one thing that we have to do, and that is we need to have fewer people who have been to these big schools, the elite. So it's the war between the big of this world and the little of this world. Anyway, we've got 4 minutes left, Antoine. I agree with a certain number of things, but not with everything. Social security is there. The system exists. It provides top quality services. And so I don't see why, given the current state of things, we need to challenge it. It would be very difficult to do that. It would be terrible financially. However, here's a proposal. Let's get rid of the CADES. The CADES has anesthetized the system without realizing the deficit of the system. I think it was a good initial idea, but it anesthetized the system. It was supposed to help. It was supposed to be reimbursed over a period of 15 years, but it didn't work. Now, concerning the question of the public service, I didn't really want to get into this, but we realized that the hospital public service is it's in tatters. It was deleted by Bachelot. It wasn't reestablished wholly with the Turin law because anybody can use it. So there's a complete legal confusion that we are experiencing. The hospital public service from a legal point of view is in tatters. Thank you. And I'm not the one who says it. State advisors say this. Gentlemen, how do you react to this? What is your conclusion? And what are you taking away from all of this? Do you feel reassured or not? No, not yet. No, not yet. Just in a word, technology industry is a virtuous circle. It creates jobs, it creates wealth. But for this to work for the healthcare system, we have to create wealth. Wealth for the moment is being created elsewhere. All small companies are then sold, and then the technology is no longer used on French patients. So we're shooting ourselves in the foot. So it really has to be a virtuous circle. The other thing is that for 10 years now, we've been offering these measures. They've been changing slightly, but they haven't been implemented. They need to be implemented. The change is for now. What about you? I just have a few words to say. Trust, pragmatism, audaciousness, confidence, trust. We need to work with people, with patients, with personnel. We need to frame the problem according to our day-to-day life. That's how we will build up trust. Pragmatism, well, we have to have debates, top-level debates, but also work on patients. And audaciousness, that's a French thing. We don't want this to be stolen, taken away from us. Thank you to all of you, and well done.